The first thing that's absolutely essential is atraumatic extraction. Now, with atraumatic extraction, it's absolutely essential that you split the roots into 3 in the upper molars and into 2 in the lower molars. If one grabs a forceps and tries to do extraction of these teeth, you, without a doubt, going to either damage the buccal plate or you're going to damage the furcation bone. And it is absolutely essential that you try to preserve the furcation bone as much as you can so that you can utilize that bone for primary stability. Flap evaluation was done for pathology visualization only. Okay, and I'll just go a little bit here into a little bit of our study design to tell you what kind of patients we included and what kind of patients we didn't include. The only patients that were excluded from immediate molar placement in our study were patients who had active perio disease. In other words, patients who did not have any treatment whatsoever. So the first thing that we did was that we gave the patients, put the patients through a perio regime. We made sure that they had all their perio treatment taken care of, and we gave them a 2-month healing period plus supportive periodontal therapy to make sure that they were under control. Other than that, smokers, non-smokers, patients who had apical pathology were not excluded in the studies at all. In fact, a lot of the times, a lot of these cases had apical pathology, and you'll see the results that we got when we deal with that. But when we had pathology, it was very important that we opened up a flap, because what happened is that we found that we couldn't visualize the flaps correctly. So it is very, very important that we raise the flaps. And from these 2 slides that you can see, you can actually see inside on the left-hand side where you can see the granulation tissue and the abscess material, and you can see how clean we had got it once we raised the flap in this case. So very, very important to raise a flap when there's apical pathology. The osteotomy preparation was dependent on how thick and how fragile the interradicular bone was. From this case, you can see that we used drills. The normal drills were used to prepare the furcation bone. And if you have a look at this case, you can see quite clearly that the implant is firmly encased in bone all the way around. And again, using wider diameter implants, one would destroy all that bone, and all one needs to do is use the 3.5 millimeter drill, the A drill with the ankylos, and you can get great primary stability with these cases. Okay, in thin bone, all right, where we had very thin interradicular bone, it is not a good idea to use the drills, because even the thinner drills, one gets a small amount of cavitation. And if you can't stabilize the drill, holding the drill nicely, what one needs to do is one needs to use piezo. Okay, there is absolutely no cavitation, there's no lateral movement with the piezo, and one can very accurately and very simply place your implant in the furcation bone. And on the right hand side, you can see from here, you can see again a perfectly placed implant in the position that it requires, and you can see that it's got good stability both from the furcation bone on the lingual side and the furcation bone on the buccal side, giving it a 50 Newton turn-in torque with great primary stability. When we had a situation where the bone was very, very soft, and this was always in the maxilla, or in a situation where we had to do vertical sinus lifts, we used an osteotome technique. And when it obviously an osteotome with a Summers curve in it, if we were doing vertical sinus lifts, or a normal bayonet, if it wasn't, it was just for condensation. And then we got to placed our implants using the osteotomes in these cases. The one thing that's very, very important that we learned very early on in the study is that it is very important to place the implant about 1 millimeter below the crest of the furcation. One of the reasons for that is that with the vertical height that one loses in these cases, if you do not place it a millimeter below, one generally will get the implant sitting a little bit too proud in the osteotomy site, and therefore one has a little bit of a problem with the restoration. So with this type of scenario, one wants to place it a little bit deeper and about 1 millimeter below the crestal bone. And here you can see quite clearly in this one, it's just a millimeter below the furcation bone. So one doesn't follow the buccal plate, which one normally would do in the anterior or in the palate in the premolar area. One has to follow the furcation bone. It's very important, because if you follow the buccal plate, you will generally end up a little bit proud, and it'll make your prosto reconstruction a little bit more difficult. All right, another thing in the mandibular area, what we find is that implants often start in the furcation and end up in the mesial root. One of the reasons for this is that the teeth normally go towards the back, and if one has a look at the tooth behind, one can see, I'll just get the pointer there, if one has a look, you can see that this tooth curves backwards, as does this one. And if you have a look at the implant in position, okay, you can actually see how it starts in the furcation and how it ends in the mesial root. And if you look at it in relation to the tooth adjacent, it's parallel to the front tooth, which is essentially what we want to do to make sure that our front tooth has the best papilla, and to make sure that we get as little food impaction as possible in our embrasure spaces. All right, now this is something which will be a little bit more controversial and which some people might find a little bit strange. But the voids here, we always fill the voids with synthetic bone. Now we know from our jump gap, from Botticelli's jump gap studies, we know that anything more than 2 millimeters needs to be filled. And we filled all the voids wherever we could. We filled these voids with synthetic bone. The bone generally that we used was bovine bone substitute. We also now using porcine bone substitutes and different stuff like that. You can use demineralized freeze-dried bone, but essentially you have to fill that. You have to fill that jump gap. It is absolutely essential, because without filling it, there's no ways that the clot on its own is going to help stabilize it. So you absolutely require it. And in every situation, we fill the voids with bone substitute. Now the question comes down, as you saw with that previous slide, is that a lot of the cases we've got no primary closure, and the question comes down to, is primary closure absolutely necessary? Now Cafiero and Carlino in their study showed that primary closure is not necessary. They didn't do any primary closure at all. They repositioned their flaps. And if you look also at the studies of the ridge preservation studies, there are a number of studies that show that the flaps were placed back without any membranes, without anything on top, and that regardless of what was done, they got the same type of healing, whether you use primary closure, non-primary closure. And in a study by Darby, Chen and Boozer, a systematic review on ridge preservation for techniques for implant therapy, their conclusion was that it would, and I'll quote this, it would appear that ridge preservation can be successful irrespective of closure techniques. And this is something that we thought about, and it kind of goes for where we're going. Let's talk now a little bit about soft tissue management, okay? How we manage the soft tissue, and this goes down to the primary closure or no primary closure. Now, in 120 cases, what we did was we got flap apposition. Now, flap apposition is very different to actually raising a flap and doing flap advancement. All we did was that we closed the tissue around, okay, using sutures. We closed the tissue as close as we could. If there were voids, we left the voids. We didn't try and raise flaps to get primary closure. If you have a look at this case, this is a 2-month follow-up where you can see the healing in this situation 2 months later. And I also want you to have a little bit of a look inside you. You can see a little bit of the granules, a little bit of the bone granules on top there, but essentially a fantastically well-healed socket 2 months post-op. In 10 cases where we had poor primary stability, what we did was and these were all in the maxilla due to the quality of bone, what we did in these cases was we did a rotated palatal flap. In one case we did a buccal advancement, but the remainder we did the rotated palatal flap, and the reason for that was so that we didn't alter the attached gingiva or the gingival line, the gingival line on the buccal side, and we also augmented the soft tissue at the same time, and we got fantastic soft tissue results in all these cases. But these were only for the cases where we got poor primary stability. And this is one that blew me away. And this was the cases where we did no flap closure at all. In other words, we didn't do any apposition at all. We didn't do any flap apposition. We did no closure whatsoever. We left them as you see them in this case on the left-hand side. Now, the reason why we started to think this way was that every time we placed a healing abutment in the implant, we found that when we rinsed out the implant itself, that none of the bone that we had placed was washing out when we were vigorously washing the area. And what we found was that the clot itself had stabilized the bone to such a degree that it didn't move anywhere. And what I'm going to show you is a series of cases, and we have 20 which all showed the same results. This is a result which you can see. This is what it looks like 1 week later. And funnily enough, we've seen a couple of cases 1 or 2 days later, it looks pretty much the same. So what seems to happen in these cases is that within a week, the elastic fibers contract so quickly that they very quickly close up around there, and there's not too much to show. On the right-hand side, you can see now a 1 month post-op where things are starting to heal very, very well. That's what it looks like 1 month afterwards. And here you can see what it looks like 2 months afterwards. And I think you'll all agree that the healing going from this situation to that situation in 2 months is pretty fantastic. And I don't think if there was bone loss, there's no ways you'd get the type of healing and the beautiful type of soft tissue healing that you've got in the scenario if there was bone loss. Now the question comes down to, are membranes necessary? And a lot of the studies did say that they prefer membranes taking place. But again, we talk about the stuff Tolman, Grunder, Becker, Chen, Botticelli. They all showed in immediate placement that where they did control studies, whereby they showed that in cases where they did bone and membrane, or cases where they did bone alone or where there was membrane alone, the membrane really made no difference. And in all the cases they showed, they said their conclusions were that the membrane was not necessary. And under those circumstances, we as well went away from the membrane placement. And on top of it, if one also looks at studies, the one thing that we find is that when there are complications in immediate placement, the most common complication in immediate placement is exposure of the membrane. And in cases where they used non-resorbable, you lost a lot of bone around the top. And in cases where there was resorbable and there was exposure, it showed that there was no difference, which means, is a membrane really necessary or not? In my opinion, not. You can disagree, there's no problem with that. Let's look at the restorative timing. In other words, let's look and see how long it took before we restored the different types of cases. Where we had excellent primary stability, basically within 2 months we were finished. So we took a case that went from there, we placed our implants, we allowed primary healing. 2 months later, that's what the implant looks like. There's the final result. Now again, look at the type of situation that we're dealing at. Look at the emergence profile of the crown. You cannot tell that these are implants. Now, the critical thing about these type of situations is, you know, whoever's placed an implant, you know that when you place a lower molar that is healed, what is the biggest complication that these patients come? They come back and they tell you, doctor, I've got half my sandwich stuck in my teeth. Because what happens is when we allow the ridge to collapse, when we allow the ridge to heal, what happens is that we end up with a huge amount of dishing just below our crown. And as a result of that, the patients are continually getting food caught in there. And they come back and they tell you, look, doc, my pastrami sandwich, look, doc, my quiche is stuck in my teeth and it drives me crazy. Every time I'm sitting there picking the thing out of my teeth and it drives them nuts. And I know that most of you will have cases like this. But the thing is that with immediate molar placement, this is a thing of the past. And you can see from all the cases that we're showing you. In cases where we didn't have good primary stability and in cases where there was a narrow furcation, we left it for about 3 months. So here's the case I showed you before. You can see with the implant in position, you can see there with the closure, we didn't get any flap advancement, we just closed up and we left everything pretty much open. As you can see, everything's open in that position over there. And here you can see the final results. In this position, there's a Zyve implant in this position over here. And we had done at the stage, this was about 8 years post-op, we had done a sinus lift over there, so we had bone within the sinus already. We didn't have to do any vertical augmentation or anything like that, which was lucky for us. And here you can see the result. And although this patient had lost vertical, the critical thing is that they haven't lost any any buccopalatal dimension, and it still looks like the tooth is emerging from the gum without any collapse of the tissue. In cases where we had poor primary stability, what we did was we did our osteotome technique. We placed our implants. We got our primary closure using the rotated palatal flap. We would generally come back here between 4 and 6 months, depending on how stable the bone was. And here you can see the cover screw coming out in this scenario. Here we're just taking the cover screw out of the implant, and you can see how fantastic the bone looks around the implant. You can't even find the implant. And here the final results of this case. There you can see the final result. This is 3.5 years post-op, and there you can see the results. Now again, I point you to the fact there is no buccopalatal dimension change, and the tooth itself, the crown itself, looks better than the teeth on either side. All right, I just want to show you something. If you think that your job's dangerous, I just want to show you what my backyard in South Africa looks like, and that's what the backyard looks like for everybody who wants to know. But I also want to just show you a little bit. Look how happy this lion is. In fact, if we played a video, this guy would be purring. I don't want to know what this person thinks they're doing with his job. But anyway, a little bit of fun. All right, let's take you through a couple of cases that we've done over the years with immediate mandibular molars. And here you can see a case that's lost all the bone in the furcation. There's a fracture. We looked at placing a 9.5 millimeter by 3.5 millimeter implant directly into the furcation. There's the implant in position with the cover screw. You'll notice we also use, for those of you who know the ankylosing system, we're using the anterior balanced base abutments. And the reason for this is that they're so big that they tend to cover a lot more of the position, of the bone, and therefore it's got less for the elastic fibers to close up, and it maintains a much better space for your molar placement. I forgot to mention in the beginning, for those of you who want to ask questions, we are going to have a question time answer afterwards, and I'll try and answer as many questions or as many comments as possible, so please hold on till the end. Sorry, I should have mentioned that right from the beginning. Here you can see the implant in position and the result. Now I take you again, I want you to look again at the way that the implant is coming out, the crown is coming out of the gum, and again there's absolutely no space for food to get stuck in these areas. And again you can see there's absolutely no space for the waffle, there's no space for the pastrami sandwich, and it gives us an excellent emergence profile every single time. In immediate maxillary molars, I have to say, I think this is probably one of my best cases that I've done. Here you can see, I showed you this case earlier with the molar in position. There, that's exactly how we left it. We did no buccal flap advancement whatsoever. We left that in position as is. That's what it looked like a week later. There was the x-ray. And that's the x-ray 2 years post-op. Now I want you to have a look how fantastic the consolidation of the bone in this case is, and how the bone has remained absolutely intact, and it looks pretty much like a typical ankylosing implant with the bone going over the top. This is a 3.5 by 9.5 millimeter implant. We did no vertical sinus lift in this case. We had just enough bone, and you can see how well consolidated the bone is. And that is the aesthetic result, which as far as I'm concerned, for me, is pretty much one of the best. And the implant crown over here and the emergence profile looks pretty much even better than the crown in front. I'm sure you'll all agree. Again, a lot of immediate maxillary molars with vertical sinus floor elevation. With this type of scenario, with immediate molar placement, what I find is that I'm doing far less lateral window sinus lifts, for the pure reason that when we take out a molar and we allow it to heal, a lot of times what happens in these scenarios is that we get the pneumatization of the sinus, we get the vertical collapse, we get the collapse from the top, we get collapse from the bottom, and as a result we end up with 4 or 5 millimeters of bone, which now requires either an internal sinus lift on its own or a lateral window sinus lift, which number one increases costs dramatically, number two increases patient discomfort dramatically, and number 4 decreases patient acceptance. Whereas with the immediate maxillary molar patient with the vertical sinus flaw, we end up with a very simple situation whereby we can very, very easily remove a tooth, place the implant at the same time with a small vertical sinus lift, and you can see in the scenario, you can see where the sinus was down here, and you can see the new sinus flaw up here going over the top of the implant, and the aesthetic result again. In this case, though, we didn't get enough attached gingiva. You can see we've lost attached gingiva, but still, we didn't lose any of the buccal dimension. So we still got the correct dimension. We just don't have as great a attached gingiva in this case as I would have liked. But still, I'm very happy with the case. We do get sometimes where with trying the verticals, we either get problems whereby the sinus flaw is much lower than we expected, and it comes down. It actually drops down into the furcation. And in these kind of cases, we actually have to do lateral windows at the same time. And I'll take you through this case here. We have a tooth in the first premolar in this situation, which had a massive amount of palatal caries. There was root caries on the case, and it ended up in an endo. And we decided with that, and with the thing that there was no purpose in trying to keep the tooth. When I took the tooth out, unfortunately, I broke the entire buccal plate, as one can see here. And we kept the buccal plate intact, and here you can see we'd re-screwed the buccal plate down over the implant because we still had fantastic stability from the rest of it. And here you can see at the same time we did a lateral window sinus lift. We got excellent lift, and you can see over here as well the little screw holding the buccal plate in. And then this one took about 6 months, and we came back 6 months later. This case is now 2 years old. These are x-rays I took the other day. And here you can see again the aesthetic result in this case with the lateral window sinus lift. Again, the best tooth in the mouth, and you can see all these other crowns which are not looking great. But, you know, these are guys that, you know, that he's not really that keen to go and chop and change everything. He's a farmer. He's happy. He can chew his ribs, and he can chew the rest of the stuff. And again, no buccal loss. Even though we lost the buccal plate, we managed to replace the buccal plate. And 2 years post-op, we've got a fantastic result aesthetically and functionally. So let's look at the complications. Okay, for those of you, these aren't my children. Okay, don't know how they cleaned all this stuff up. But from the studies that we had 3 failures in 3 years, and we're now actually onto our 4th year, and we're still sitting with 3 failures. And I'll go through each one of these failures. This one failed. This is the only one we even had flap apposition, and in this case, you know, we actually got fairly good closure around the implant, but still the patient got an infection. And this was the only one that actually got an infection that was fairly painful for the patient. He had a lot of post-op pain. He came back, we tried to rinse things out, but eventually we took the implant out. We had to allow it to heal, and then we went on and did a lateral window sinus lift with an implant at a later stage, and he's now got his crown back, but this one was a bit of a problem for us. This case, you can see this molar over here was in function for 6 months. And as you can see again, we got fantastic stability of our buccal tissue. Everything looked great. We had 2 implants. This was also an implant. We put 2 implants next to each other. And this patient was a heavy smoker. She smokes about 30 to 40 cigarettes a day. That's a possible cause of the problem. But the thing was, it was in function for 6 months. And 6 months later, she walked into my surgery with an implant in her hand saying, "Look, I'm sorry, but the implant's fallen out." Why it came out obviously wasn't integrated in the first place, possibly as a result of the smoking. But she's the only one where that happened. This one I cannot explain under any circumstances. This was the photo that I took of this case at 3 months post-op, and I'm sure everyone will agree that if you look at your cases and they look like this, you'll be very, very happy. And I turned it, I torqued it, everything looked great, there was no pain whatsoever. She went on to her dentist, and once she went on to her dentist, she found he turned it a little bit tighter, and there was slight movement, and he gave her some local, and he took the implant out. And again, the nice thing about it was just fibrous encapsulation. There was no actual damage. There was no massive destruction of the bone. So with 2 months later, we were able to place another 3.5 millimeter implant, and she's subsequently had everything restored, and she's got no problems whatsoever. This was a case that I had whereby we actually lost bone. If you have a look at the x-ray, We lost bone around that side, and I must say 6 months post-op I was hell of a worry, and we informed the patient about it. There was no problem, there was no suppuration, there was no bleeding on probing or anything like that. So we kind of watched it, and this case is now 2 years post-op, and you can see it's still pretty much the same. It's pretty stable. We've got no problems around it. It's still functional. Patient also was a smoker, but now stopped smoking. And here you can see the aesthetic results and the results of the soft tissue. Again, no suppuration, no bleeding, everything happy and healthy. So this is one that we got on the back burner. We're watching it as much as we can, and we check it every 3 months, and we see what happens from there. On the odd occasion, we also had some soft tissue irregularities whereby we had to do a little coronal repositioning of the flaps, which we did to try and get things a little bit better. And you can see the healing around there, very, very nice. And here you can see again the molar in the 7 sites. Great aesthetic results, a shocker on the tooth in front. But again, you know, it's difficult with guys when you try and tell them you want to try and improve on the aesthetics. They don't really give a damn. And we've got a great tooth at the back, but the one in front looks slightly bad. But you can see that the change in the soft tissue is nice and stable, and that's about a year old, that case, and very happy and healthy. I just want to take you through a case which I did, whereby this was a case where he had implants about 4 or 5 years ago, and I want to show you what the difference was. Now, this is the same patient on the lower and the upper, and this patient had external hexed implants placed in both the premolar and the molar area. And I placed an implant in the 7 area, in the upper right-hand side, in the second molar region. And I'd also placed an implant in the molar area down here. And this was an older implant. None of these I'd placed. But I want you to see what has happened when the area was allowed to heal in both these sites. Okay, they were allowed to heal. And in both these sites, you've got problems with the soft tissue. You've got problems with soft tissue collapse. You haven't maintained the ridge. And a lot of times what I think that we are doing in these cases, by putting the synthetic bone around the implant, we are actually doing a ridge preservation at the same time as doing our implant placement. And it is that fact, it is that placement of the ridge preservation at the same time, which we know will help us to preserve our ridge width from our ridge preservation studies, that we get the type of results that we are getting. And here you can see the results. Here you can see this one. We've splintered that one onto there. And here you can see the pre-op. We've lost a little bit there, but the aesthetic result is still fantastic in this case. I haven't got one of the crown on top, but here you can see the crown, the implant next door, and a fantastic result in all cases. So if we look at the result summary, we take 150 immediate molar placements. All had a diameter of A3.5. They ranged in length from about 8 to 14 millimeters. We have up to 3 years. Now it's up to 4 years, but at that stage it was up to 3-year follow-up. And of that, we had 3 failures and 98% survival. So I think you can all agree that with 98% survival, this is really a viable treatment option. And the fact that we can use narrow diameter implants instead of going for the wider means that we can start placing these implants in far more cases than one would if one was using the wider diameter implants that require the apical bone, that require the buccal and the lingual plate to give us that stability.